This is the final round of this year's, the 2018 Madison Cup debate tournament. So I'm going to give a few thank yous, talk about our format, and then I'll hand it over to our moderator. So thanks all of you for attending. I always worry when the sun comes out and the weather turns nice that nobody will show up. So I appreciate you all being here. I wanted to thank the JMU debaters who both competed today and helped us run the tournament, stood out in the rain this morning to hand out parking passes and all of that sort of thing. We couldn't do without them. So let's give them a round of applause. I want to thank our community judges. The tournament today is judged by individuals who are from across the university and across the community. And they do it because I asked them to, out of the kindness of their heart, and we really appreciate it. One of my favorite parts about running this tournament is watching individuals from across the university who don't normally get to interact with each other get to judge together, and I listen in on some of the deliberations. I get to hear what different people think are important about the topic of healthcare, and I think it's really interesting. So let's give them a round of applause. I want to thank the Madison Cup committee. I'm the chair of that committee, but I definitely could not do it alone. So I'd like to thank Al Highland, Abe Goldberg, Kathy Clark, Lindsay Shook, and Christy Saindon. Let's give them a round of applause. I'd like to thank our grant sponsors, the Arthur N. Root Foundation. They provide $45,000 in grant money that goes to travel stipends, team awards, and which some things all the debaters are going to be happy about is individual awards for the debaters who are up here on stage. So just by making it to the final round today, each of these debaters will receive at least a $1,000 prize from the Root Foundation. So let's give them a round of applause. So this format is a little bit different from debates you might have seen because the teams on each side are competing against each other, but also against the teams that are on the side with them. So the affirmative teams and the negative teams will be ranked at the end of the debate by our judges from 1 to 3. We'll rank the top 3 for prize money, but you'll also see them collaborate. So it's a really interesting process. The first speech on either side is 4 minutes and uninterruptible, but after that, the middle speeches are 5 minutes, and the middle section of those speeches can be interrupted by someone from the other team. So you'll see someone stand, and the speaker will decide whether or not they want to take that question. It's an interesting format that I really like. A couple reminders. At the end of the debate, make sure you hand in the ballots. We'll announce an audience winner, but also if you're here for extra credit or SONA credit, that will count as your credit, so make sure you hand that in. And then while our final round judges are deliberating, there are microphones up front. If you're an audience member, you come ask questions or make a floor speech, and then our moderator will choose the person they thought gave the best speech for an audience prize. The last two things I have to do today are introduce our final round panel and then our moderator. So our final round panel is Heather Coltman, Provost and Senior Vice President for Academic Affairs at James Madison University. We'll clap for each of them. John Alger, President, James Madison University. Gina Reed, Mayor, City of Harrisonburg. Abe Goldberg, Executive Director, James Madison Center for Civic Engagement. And Eric Major, Chairman, CEO, and President of K2M, and more importantly, a JMU grad and a JMU parent. So let's give him a round of applause. And finally, I'll introduce our moderator, Dr. Sharon Lovell. She's the Dean of the College of Health and Behavioral Studies, and we're really happy that she's agreed to moderate this debate for us tonight. Sharon?
Good evening. I'd like to thank our competitors for participating this evening, and I want to introduce our timekeeper, Ryan Wardock. So we're going to start with our first affirmative speaker from Bossier Parish Community College, who is Dominic Mercer.
All right, before we get started, I want to give a couple of thanks. First, I want to thank JMU because this tournament has been one of the best tournaments I've personally had or ever been a part of, and the clash and the debate between it and what I've learned from this, I will take home, and I hope the competitors also will take it home. But further from that, I want to thank Dr. Bateman, who's the Chancellor of Bossier Parish Community College, and the entire Bipsy family for allowing us to come to this university and do this debate. Further than that, I want to thank my teammates, starting with my coaches, Coach Bob Alexander and my coach Preston Langley. Both of them have taught me things far outside of debate, which is way more than I expected. And then lastly, I want to thank my teammates, Steve Garcia. This will be our last debate together, and it's going to be a great one, I can promise y'all that. But with no further ado, let's get into it. Memento mori, a Latin phrase from the Crusades meaning, remember, you will die. This is extremely important to remember because while death is inevitable, what we see in the modern day United States is that those of the lower class will be forced to remember a lot quicker. A study done by the Harvard Medical School and Cambridge Health Alliance published in 2009 by the American Journal of Public Health found that the uninsured working age American has a 40% higher risk of death than their privately insured counterparts. Lack of health insurance causes 44,789 excessive deaths annually, more than kidney disease. Every other developed nation has achieved universal health care through some form of nonprofit. Our failure to do so means that everybody's pays more and some pay with their lives. That's why I rise in support of the topic that this House believes that the United States should provide universal health care and comprehensive coverage. The American Medical Association in 2015 notes that the uninsured are 3 to 4 times more likely than those with insurance to report problems getting needed medical care, even for serious conditions. In one study, more than half of the uninsured postponed needed medical care due to financial concerns, while over 1/3 went without physician-recommended medical test or treatment due to financial concerns. For those fortunate enough to be able to afford health care, it pushes many functionally below the poverty level. The Commonwealth Fund in 2011 found that if health care costs were subtracted from family incomes, 10 million more people in the United States would be officially poor. 2 million more children, 5 million more working-age adults, 18 to 64, and 3 million more adults ages 65 and older would fall below the poverty threshold. That's why we advocate adoption of a German model of universal health care to ensure comprehensive coverage for all. A UCLA study from 2014 details a 17-year examination of health services of 27 income countries and their efficiencies at turning dollars into extended lives. The United States was near the bottom, ranking 22nd. Every additional $100 spent in the United States was associated with a gain of less than half a month of life. In Germany, more than 4 months of increased life expectancy were associated with every additional $100 spent into the system. The Organization for Economic Cooperation and Development's data illustrates the difference between the German and the American systems. Annually, Germany spends $4,297 per citizen, while the United States spends $9,892. In terms of GDP, Germany spends 11.3%. The United States spends 17.2%. What do we get for these extra expenses in the United States? 5-year cervical cancer survival rates, Germany is at 65.2. The United States is at 62.6. 5-year leukemia survival rates, Germany is at 91.9. The United States is at 89.5. Despite huge expenses, Americans do not receive enough treatment. U.S. 19.9 skip consultations due to expenses, 2.6 in Germany. In the U.S., 19.8 skip treatment options due to expenses, 4.4 in Germany. The U.S., 18% skip prescriptions due to expenses, 3.2 in Germany. We advocate a system modeled off the German system to phase off Medicare and Medicaid, establishing sick funds that act as managers and negotiators, add an additional 8% to employers and a 7% employee payroll tax, which 2015 figures from the Tax Policy Center show generate just over $1 trillion a year, meaning that this is sustainable within the United States, and all these benefits that Germany sees, we can see within the United States. And so for all these reasons, we see specifically that the German healthcare model is the system that we should go to in the United States, is the one that's flawed. Continuing on, this will be a challenge, but it's a challenge worth rising to. As Walter Cronkite once observed, the American healthcare system is neither healthy, caring, nor a system. It's time that we get it right. It's time that the United States provides universal healthcare and comprehensive coverage for all.
The first negative speaker from Yale University is Quinn Crawford.
Thanks. Before we begin, I also have some thank yous I'd like to make. First, I'd like to thank James Madison University for hosting such a wonderful tournament. It was a 10-hour drive, but we're really happy that we get to be here. It's had an awesome time. I'd like to thank the Arthur and Root Foundation for obviously giving out these nice rewards for us. And I'd like to thank my partner, Jordan. He's been great. And I know what you're thinking, but no, not every guy who goes to Yale looks like Justin Bieber. So, is everyone ready? Great. Because the road to hell is paved with good intentions, we're proud to oppose the motion. So the key question for this round is, what does the trade-off actually look like? We need to consider whether universal health care actually translates into better quality of coverage, especially for the least advantaged. With that said, we have 3 arguments that we'd like to advance. The first argument is about government obligations. We can accept that the government has an obligation to help the least advantaged members of society, but this means supporting and expanding programs like Medicaid that are directly targeted towards the worst off. It does not mean the government has an obligation to force all others in society to accept government-supplied health care when they don't need it. A system of universal health care strips away from all individuals the choice of medical insurance and medical provider. The right to choose a particular package of services touches on a whole host of personal issues, from reproduction and birth to suffering and treatment. There's no need to strip the fundamental right of people to make choices about their own medical decisions. In fact, intervening in the healthcare market in this way would constitute a serious overreach of state power. The way to help the poorest Americans is not to play to the lowest common denominator and lower the quality of care for everyone. Instead, we should target healthcare policy towards those who need healthcare. Reforming Medicaid and making it more accessible to more Americans in need of it is a much better strategy than scrapping the project entirely and imposing a universal system. The second argument we want to make is about better health outcomes that are going to occur on our side of the house. In the status quo, doctors specialize in particular areas of medicine after getting a general MD because they know that these fields offer large salaries. But when these salaries go down, which they necessarily will when a universal healthcare system is implemented, there's less incentive to specialize. What does this mean? In countries with single-payer systems, doctors focus on being a general physician or a general surgeon as there's not enough pay potential to specialize primarily into being like a cardiac surgeon or a transplant specialist. Universal healthcare means doctors become expected to have general knowledge of many procedures instead of in-depth knowledge on a handful of procedures within their specialty. Quite simply, this translates into worse health outcomes. A 2016 study by the British Journal of Anesthesia found that the US had the lowest in-hospital mortality of 3% for elective inpatient surgery. Empirically, profit incentives for doctors to specialize encourage better treatment practices with more skilled doctors, which translates into better patient outcomes. The point is, even if treatments are more expensive, at least they exist on our side of the house, and private insurance and Medicaid is more likely to cover most of the costs. We also think that pharmaceutical companies will be less likely to invest in research and development in the affirmative world. A huge reason why companies develop drugs and medical technologies is because they know that they will run a profit from them in the long term. If you accept that costs will go down, this simply means that there's less money for research and development, which destroys medical innovation and prevents improvements in medical care in the future, which results in a net harm. The last argument we want to make is about the economic harms of implementing universal health care. Most sources estimate that somewhere between 8% and 12% of US GDP will need to be spent in order to finance universal health care. This is over $1 trillion annually, and this money doesn't come from nowhere. It has to be redistributed from other sectors. According to the Wall Street Journal, the financial resources devoted to universal health care are most likely to come from, quote, K-12 education, public universities and colleges, veterans affairs programs, and other much-needed services, and by raising sales, income, and property taxes. This is especially harmful for the poor, who are disproportionately more likely to lose access to these services in the absence of government funding. Further, according to the Census Bureau in 2016, the vast majority of Americans get their insurance through employer-based coverage, meaning the cost of insurance is footed by companies, not individuals. We think that when you shift to universal coverage, companies have no incentive to provide health care, so people will receive the same pay, but now face much higher tax rates to compensate for the government coverage, meaning individuals walk away with worse quality coverage and less money. For this reason, we are so proud to oppose. Thank you very much.
The second affirmative speaker from Bossier Parish Community College is Steve Garcia.
Before we get started, I want to extend a few thank yous, of course. Of course, to JMU. This is my first experience on the East Coast. It's been really, really great. To, of course, all our BIPSI people, Dr. Bateman, our chancellor, could not be more supportive of the debate program. Our BIPSI family, including our coaches, Bob Alexander and Preston Langley, of course, my partner, Dominic. So, thanks to everybody else for making it here. I'm sure it's going to be a really good round. With that, let's go ahead and jump right into it. Now, coming out of that last speech from the negative, well, we hear this big idea of, well, we have to understand this trade-off that comes with universal health care. And, we absolutely do, but the trade-off does not come from establishing universal health care. The trade-off comes from continuing with the status quo. Now, what we have to understand is that estimates say the uninsured is actually going to continue to grow by 2020. We're going to see millions of more people being uninsured. So, further on, he talks about this idea of, we see this government obligation to help the least advanced. Now, what we need to understand is that there's two different poverty measures. There's the poverty measure the government uses, and then there's the supplementary poverty level. Under the supplementary poverty measure, we see another 11 million Americans would fall under this threshold. Unfortunately, Medicaid doesn't account for this. Unfortunately, private insurance does not account for this because statistically speaking, these people are doing just fine. We as the affirmative stand to say that no, they are not, and they need help. Further on from that, they talk about how there's better health outcomes here. When we look specifically to Germany, we see that Germany has more doctors on average than the United States does. First of all, according to the Organization for Economic Cooperation and Development in July of 2016, Germany actually has 4.1 doctors per 100,000 people. Germany has more doctors than average across the OECD, including the United States. This is a system that's been in place for decades, and they have more doctors than we do. Now, further on from that, they talk about how we see private insurance and Medicaid can solve. Well, let's actually take a look at this. We see that private insurance, while rates have gone down through employer-provided health care, we're seeing that is not going back to the people, to the actual workers. Yes, ma'am.
So if Germany's system functions because it has more doctors, how do you expect this affirmative system to be able to function at the point at which we don't have as many doctors as them, and you're ruining the incentives to become a doctor?
Well, but that's the brilliant thing, is what we see is Germany's actually adding more doctors per year than the average OECD nation. And so by adopting the system, not only will we have more doctors per people, but we'll also have more doctors to begin with. Yes, sir.
Me on the end?
Either one.
Okay, so how do you respond to, according to NPR, the German system, doctors meet certain amount of quotas with meeting with patients, and then they leave and go on vacation when they meet that cap. How do you respond to that when citizens aren't going to have access to these plethora of doctors that you talk about?
Well, keep in mind, we're advocating specifically for a German-like model. Obviously, we didn't have time to list out every single fraction of what we're going to be doing, but we will ensure that people do have this coverage when they need it. All right, so continuing on with what the last negative was saying, he talks about this idea how we're losing in this investment and there won't be any more money put into research and development. Now, what we have to understand is that the European Commission of Economic Policy Committee in November of 2016 found that since 2011, the AMNOG, which is German pharmaceutical laws, obliges producers to verify the additional therapeutic benefit of new patented medicines. Now, that's a lot of fancy words. Let's talk about what that means. So essentially, the government of Germany incentivizes companies to go out and invest and make new products and actually rewards them with coming up with new therapeutic benefits. When we look to the United States, under the status quo, roughly 80% of research and development money actually comes from the National Institute of Health. So we're actually not going to be losing any money. We'll see more actually coming in. Further on from that, he talks about how, we're going to cut education, we're going to do all this, we're going to do all that, but my partner provided in his very first speech the funding mechanism as to which we will do it, which is cheaper than the status quo. Yes, sir.
I have a question about the plan specifically regarding pharmaceuticals.
Yes, sir.
Is Big Pharma going to be socialized as well, or will that remain the same?
There will be negotiations between the sickness funds that we discussed in our first speech and the pharmaceutical companies. Now, so let's get into more and talk about the affirmative case a little bit more. So we have to understand that the U.S. is incredibly inefficient when looking to healthcare. So according to the Eastern Economic Journal in 2017, the U.S. spends more on healthcare than any other developed nation and yet achieves lower levels of health, ranking 28th in terms of life expectancy at birth among the 35 OECD countries. It is evident that our system is failing. But further on from that, we see that there is an extreme lack of disproportional coverage that impacts minorities. The Journal of Social and Political Psychology in 2016 notes the data from 2010 demonstrates that non-Hispanic whites had the lowest uninsured rate, whereas racial minorities had higher uninsured rates. With blacks it was 20.8% and Hispanics it was 30.7%, being among the least insured. The affirmative reduces this problem within society. But further on from that, we see the benefits that come from the German system. We see, according to the European Commission of Economic Policy Committee, they're actually introducing health cards, which allows you to go to any hospital. You swipe this card and they can instantly pull up all of your records, meaning it's a lot faster to get healthcare. It's a lot easier to get healthcare. But further on from that, they actually actively invest in weeding out corruption, trying to make sure everything's running stable, unlike the 10% of administrative waste that we see within the United States. The advocacy of the affirmative in today's round is not only more efficient, better quality, better access, more comprehensive, but we see ultimately we will be able to establish a plan that takes care of the people.
The second negative speaker from Yale University is Jordan Farringham.
All right, once again, not to be too repetitive, just want to say some thank yous. Thank you to Jamie for hosting this tournament. Thank you to all the esteemed judges who are here to watch the final round. Thank you a lot of the competitors for sending me. This is like the third time I've had a round with you today. Made some great friends today. It's been fantastic. Quinn, super excited for our 10-hour all-nighter road trip back tonight. And with that, I will begin. Society Affirmative places a lot of emphasis on how the costs are going to decrease under our universal healthcare system. Let's take an analysis of how the US currently spends so much on healthcare. The reason why the US is spending far more than most other countries on healthcare systems is because the US is allocating a lot of that money to specific groups who need it. That's why 50% of healthcare costs cover 5% of individuals who are the elderly. What happens within most healthcare systems, like the ones they propose, everyone receives a blanket basic level of care, but they don't receive in-depth coverage when it's needed. What we do on Side Negative is we keep the current status quo plans, such as Medicare and Medicaid, which specifically target groups who are at need. So rather than say they're receiving $5,000 a year worth of coverage, what happens now is these communities who are inherently at risk are receiving far more because they need more for their care. The average middle-aged individual probably isn't facing extreme health concerns in most circumstances, but the person who is 75 years old, who's having some type of health complication, is going to need a lot more funding. We see that's where the comparative is. All their arguments that they give to you about how health is going to be cheaper on their side don't actually address the fact that that means there's going to be inadequate care for a lot of these individuals. We say, rather than make it so everyone gets the same blanket level, we want to make sure that the people who specifically need these receive adequate care rather than cutting them short. What else do they try to tell you here? Well, they try to tell you that you can still get this German system where we get a lot of doctors who treat these types of care systems. I'll take it in 1 second. So the German model fails for a few reasons. First off, the reason why Germany has so many more doctors is because things like public education are subsidized at the collegiate level, which means people can go to med school. We say in the US there's an inherent limitation on the amount of doctors available, which is why we look towards government-run facilities such as VA hospitals. That's why they have terrible healthcare outcomes where people are left waiting for months because they literally don't have access to care because there's not sufficient staff. But sure, I'll take your question.
How many other countries have systems similar to the German model?
Sure. So you have 30 or so countries that have universal healthcare models, but we disagree in the fact that those are actually effective. Yes, everyone will receive a blanket level of care, but we say that care is actually worse. We get these arbitrary rankings that you provide to us, but the problem is those rankings fail in a few reasons. First off, they allow the government to define what relevant health concerns are, which means if you go to a country that has a conservative-leaning government who doesn't want to use the government healthcare to cover things like birth control, that no longer becomes a relevant health concern. We say rather than allow for private insurance markets to exist, what can happen in that sense is individuals can choose what package they want to receive healthcare things that they find important to themselves, rather than having arbitrary standards defined by the government. I'll take one more question.
How many times has the VA been cut in the last 10 years?
I can't give you a specific number on how many times it's been cut, but insofar as we already see that these government-run facilities are doing terribly, and the reason why the VA is being cut is because veterans are moving away from the VA to private hospitals due to the terrible quality of care, we would say that's an active incentive why government-run facilities are inherently inefficient and ultimately don't provide good standards of care. We say, yes, maybe they get a cheap system on their side. The problem is it doesn't have the health outcomes that they try to talk about. Just citing Germany as an example and giving you 4 different cases where they have better rates of survival doesn't actually address the question, especially when those rates are probably statistically negligible. What else does my partner tell you coming out of this case? First off, he talks about the specific role of the government within this context. We agree the government needs to make sure that people who cannot afford healthcare are the ones who are actively receiving it, but they never make the comparative on which people currently receive healthcare right now. What we tell you is the majority of people, 55.7% exactly in the US, are receiving healthcare through employment-based systems, which means most people don't actually foot the cost of their bill. And in addition to that, about 37% of people currently receive things like Medicare or Medicaid funding, which means those at-risk populations are the ones who are already receiving government assistance, which means it's not necessarily people who can't afford it who are not getting healthcare. Rather, what we see is people who have the capacity to afford healthcare, such as people who are in the middle class, actively choosing to not buy into insurance programs. We'd say in this way, we'd probably rather try and incentivize these individuals to act into healthcare programs. They also try to respond here and say, well, Medicaid programs don't cover certain types of people, but we say there's still an active incentive to try to reform the status quo plans rather than completely strip these programs and give a blanket approach that just covers everyone at an equal stance. We give you a few reasons specifically why some individuals shouldn't have to foot the cost of other individuals. There's no reason why my taxes need to go up substantially, which is a point they never address. They try to say that, well, individuals are spending a lot more on money, but what we try to tell, a lot more in healthcare, but what we tell you is that companies are the ones footing these bills because it's employment-based coverage. We see in countries where there's government assistance, government-provided healthcare, those tax rates go up to like 40%, which means individuals actually get much less money coming outside the house. That's a point that Quinn gives you that they never actively respond to. What we also see specifically is that we're the only ones who actually incentivize doctors to specialize. They just try to say Germany has a lot of doctors, but the problem is there's no specialization because there's no profit incentives insofar as the government's able to only pay a minimal amount of money, which means there's no innovation in terms of research techniques, surgical methods, anything of that sort. So we agree, yes, people need healthcare, and healthcare should be something people should access, but rather than finding a blanket approach that limits healthcare access to all, we say focus it where it's specifically needed. That's why inside opposition, we say reform status quo policies rather than trying to strip those away for a program that's bound to fail because the US does not have infrastructure or inherent resources available for this. Additionally, you're going to hear a lot of arguments on side negative. They're going to sound pretty derivative of what we're saying. Just remember when you cast your ballot, who first brought up and introduced the majority of these arguments. We say it's clear ballot for -1 from Yale.
The next affirmative speaker from Liberty University is Hannah Allison.
Before I start, I just want to thank the Arthur and Root Foundation and JMU for sponsoring and hosting this tournament. It's been a great experience, and I'm really glad I got to compete here. I want to thank my opponents, and especially my partner, Austin, for making today a lot of fun and a great experience, and the judges for taking the time to judge us tonight. Without further ado, I will begin my speech. We agree with the first affirmative team. We proudly stand firm that the United States should provide universal health care and comprehensive coverage for all. We believe that this would benefit Americans in many ways, but think that the two most compelling reasons are solving access and improving the economy through decreasing healthcare costs. Our opponents have stated access to high quality medical care is crucial for a long, healthy life. As the first affirmative team said, providing national access to healthcare also solves the current inequalities and treatment gaps in our healthcare system and reduces the implicit bias that currently occurs towards minorities. According to a nationwide survey conducted by Andrew Wilper and his research team from Harvard Medical School, Americans without access to health insurance were 40% more likely to die each year after adjusting for socioeconomic, gender, and racial disparities. In 1 year, that percentage equals 44,789 preventable deaths. Additionally, the current fragmented system has resulted in massive inequality of access, putting women and people of color at an extreme disadvantage and high risk for exacerbated health complications. According to the Master of Public Health and Medical Dr. George Rust at the Center for Medicine at Florida State University College of Medicine, we can make progress towards health equity just as we have addressed economic disparity through anti-poverty programs, but only through the implementation of universal health care coverage. Finally, Adam Gaffney, a medical doctor at Massachusetts General Hospital and instructor at Harvard Medical School, argues that the failure of the government to provide health coverage was a key factor in creating the inequalities that exist today. Gaffney analyzed multiple studies and found that the VA's form of single payer has consistently delivered high-quality health care and has effectively reduced and started to eliminate some racial health inequalities. Yes.
Sure. So insofar as these people may be labeled as having health care, how are they actually going to be able to survive insofar as government facilities such as the VA have week-long wait times that eventually leads to people not receiving treatment and eventually dying from whatever malady they may have?
We believe that giving them access to healthcare, as the study shows, is going to be able to help them have access and help them be able to get treatment that they need in order to make their lives better. Yes. So the study by Gaffney also shows the impact of that political change brings major improvements. The civil rights movement positively impacted black health outcomes. For example, black infant death rates were significantly higher in Jim Crow states than non-Jim Crow states. The second reason, the Health Research Institute, we agree with all who have previously stated healthcare costs are rising. The beauty of our plan is that it solves them. They say that costs will not decrease, but according to John Wasik, an economic analyst for Forbes and Wall Street Journal, for over 30 years, a single-payer system would save money and boost the economy through 4 separate mechanisms. Yes.
Okay, so in reference to like saving more lives under your plan, how is that going to happen when the government now has the capacity, especially the hyper-partisan government here in the US, to ration certain services that some citizens might actually need to survive?
Well, I'm going to get to the ways in which we don't actually need to ration care because we are going to be able to save costs and have money to cover everyone as I move on in my speech. According to John Wasik, an economic analyst for Forbes and Wall Street Journal, a single-payer system would save money through 4 separate mechanisms. The first is administrative cost. The fragmented multi-payer system wastes billions of dollars a year on unnecessary paperwork. Under Medicare, admin costs are only 2% of total costs as opposed to the 18% of the budget which private companies spend. That is a 16% savings in operating costs through administrative cuts alone. Second is advertising. Single-payer systems spend virtually nothing on advertising, whereas private healthcare companies spend 15% on average. This is a 15% cut of current insurance completely cut. Third is price negotiation. Wasik says that the most important source of savings is that instead of each individual employer or insurer having to negotiate prices on an individual basis, the government will be able to negotiate prices for everyone at once, guaranteeing demand for doctors and hospitals, allowing them to lower prices substantially and cut costs there. The fourth saving mechanism is taxes. Though people will no doubt say that an increase in taxes always costs money, think about it this way. If you or your employer currently spend $800 a month to provide health care, and now the government provides that care for you, then even if you now pay $600 more in taxes, you still have a net benefit of $200 in your pocket at the end of the day. This means that you still save money, and money is saved overall. Robert Frank, a professor of management and economics at Cornell University, rebuts criticism of current Medicare, Medicaid, and the VA, saying that a key problem is that they currently only cover the poor and the elderly, population subgroups with the heaviest medical needs. When the government integrates everyone into the pool, these excessive costs of certain groups are offset. This answers their arguments about the VA failing and having higher costs and not being able to solve that way. Steffi Wohlhandler, a medical researcher associate at Harvard for the last 30 years, explains how detailed plans have been published in a variety of journals, including the American Journal of Public Health, and these proposals explain what that transition would look like and explain the current federal proposals, including funding for that transition, such as job retraining and placement. Thank you.
The next negative speaker from the University of North Carolina is Pallavi Gulati.
Sorry, 1 second. So, sorry to be repetitive, but before I begin, just want to thank a couple people. Thank you to JME for hosting this. Thank you to all the judges that have come out today. I'm actually a senior, so this is my second and last JMU. It's also my last tournament, so it's been a lot of fun. Alex, thanks for being a great partner. It's been great. So with that in mind, I will begin. So I'm going to let Alex do a little more of the rebuttal, but this speech is going to focus on what I think is a very important point that has not been as discussed in this round as it need be. I think we've already discussed pretty extensively how healthcare elsewhere isn't that good, but we haven't discussed is where these preventable deaths come from. So we're going to talk about that a little bit. So in the 1980s, US healthcare was actually on par with the rest of the OECD countries. That is to say, we were like 3rd out of 30 or something like that, very close to the top. In the 1980s, we also went through a series of tax cuts such that the rate dropped 23% over 3 years. It was in that same decade that our healthcare rankings shifted heavily. Now we're 23rd or to 27, somewhere in there among most rankings. Given that, it's important to look at why that happened. And largely it appears to be based on research, a result of income disparity. So why is this true? In America nowadays, like conservative estimate, 1% of the population controls roughly 70% of the wealth. This really matters in terms of how healthcare affects individuals on the ground, because it's not a purely like, I go to the hospital and get my arm fixed if I'm hurt. It's a question of what happens every day of my life and impacts the way I live. So I'm going to do a couple of areas of weighing to explain this. I'll take you in a minute. So the first thing I'm going to talk about is why income disparity is the real problem. I think there's 3 reasons this is true. The first is diet, right? Like if I come from a poor background, I don't have access to a lot of money. Keep in mind, 14.5% of Americans are under the federal poverty line. At the point at which that is true, it doesn't matter if you fix my arm if I can't get good food at home. I don't have access to healthcare. If I don't have access to good food, if I live in a food desert, where the only options are gas stations and diners. At that point, healthcare doesn't actually fit the fundamental problem, but sure.
Okay, so you talk about healthcare being up to par with other OECD countries, but in 1980, what was the average out-of-pocket healthcare cost for the average American?
So I don't know that off the top of my head, but I know it doesn't rank what it is now. But the second thing I want to talk about is exercise, right? And this comes more from like the way you live your life, right? Like if you work in a factory, you're working long hours, you don't have time to go home and exercise after work or do other things. That is simply your environment. When you live in these poorer neighborhoods, you don't have access to things like places to run at night or just walkable ground. And these kinds of issues actually pervade the way people live. James A. House published a very important work in public health policy about how these things impact people. And overall, what you tend to see over time is that the reasons that you go to the doctor, like by the time you were there, it's because something has happened that is so bad that you need preventative care. But that could have been prevented if you'd known to eat healthier, if you had time to afford the food, to go and exercise and do all the things that are often necessary to live a good life. We think the problem on their side of the house is it fundamentally puts a giant band-aid on what is a much larger issue in terms of how the US functions. We think many of these issues can be solved long before anyone gets to the hospital, right? Because it's much, much easier to treat my lung cancer if you catch it very early than if you catch it very late, right? The costs are significantly higher. So the point at which that's true, we think what you can do on our side of the house is you save a lot of money because you catch these problems early on, or you just outright prevent them by having good habits and encouraging people through things like voucher programs for housing, through things like something such as the Moving to Opportunity program, which moved people from low-income neighborhoods to high-income neighborhoods, and saw within 2 years a 20% decrease in diabetes. And that has massive changes in terms of the millions of dollars that would have otherwise been spent on healthcare compared to the hundreds of thousands for these types of programs. That is a huge difference that is much, much less expensive, but sure.
Doesn't privatization contribute to income inequality?
I don't think so in this situation. Like, privatization wasn't the reason income inequality happened. It was largely a result of tax cuts that drove down how much money the lower class had access to. So I don't think that actually that's where this issue stems from. But I think the final thing I just want to talk about is why this creates a worse and more cyclical system. So why is this true? I think there's a couple of reasons. I'm not going to take any more, sorry. So there's a couple of reasons. So think about it this way, right? If I just cannot afford to go, like if I'm in their world, and I now have a higher premium given taxes because of what they're going to do to make me have universal health care, I have to pay more money now, probably work more. If I get injured, I have to go in, get fixed, go back out and continue in the workforce, probably work longer now. And the end result of all of this is you create a cycle of poverty where people never escape because they're simply stuck there, trapped by these high premiums that are quite frankly going to be necessary if we want universal health care, are going to force people farther down the economic ladder. We think rather, if you decrease doctor demand by focusing on preventative, non-clinical care, to be clear, not clinical care, but preventative programs such as education, food stamps, etc., things that actually drive it down before they ever need to get to a hospital. You have less doctor demand, you have less sick people, premiums go down, and there's no need for a giant band-aid that will not fix the problem. Like, the problem in the United States is not that people don't have some way to get to healthcare. The problem is issues are only caught very late, and we let them get that far because of the income disparity we have. This will do nothing to fix the actual problem. Thank you.
The next affirmative speaker from Liberty University is Austin Alford. Austin Alford.
Hello, as already mentioned, my name is Austin, and I would like to thank the Root Foundation for providing this opportunity for all of us. I would like to thank my partner, Hannah, and our wonderful coach, Nick, and his beautiful daughter, Mackenzie, who's also with us today. I also would like to thank the distinguished judges for being here today. I know that your time is valuable, and I will try and respect it and make it worth your while. The question that I believe that you should ask in deciding this debate is, what are the harms that the negative says are going to occur as a result of the plan? They are already happening in the status quo. They say that there is going to be we will fail to have doctor specialization, and that will cause rationing and wait times, i.e. people will not have access to care. That is the status quo. The status quo is that we already have 28.5 million people in the United States who do not have access to care. The status quo is that every single year, 45,000 people, according to a Harvard Medical School, taking into account all those other different factors that the negative was just talking about, die, with the critical reason being a lack of health insurance. The problem, there are many other problems. There are many other reasons that people die. That was much of the most recent speech by the negative. However, those are not reasons that you should negate the plan. The plan still takes care of a major reason that people die from lack of health insurance, even if it doesn't fix everything. And I ask you, what's the best way to catch cancer? Is the best, or to prevent cancer from becoming much worse? Is it to go out and exercise, or is it to have preventative screening, to have essential care, so that you can actually catch it and prevent that from becoming much worse? Yes.
Great. So you talk about access to care. Why should we make everyone get state-run healthcare instead of targeting healthcare policy towards the least advantaged who actually need it?
That's an excellent point. So, the people that actually need it, that is the gap right now under the status quo, those 28.5 million. Some of them are individuals who do not want health care, that don't need it. Many more of them are people who have too much money to be able to enroll in Medicaid, but still do not have enough money to then be able to purchase health care on their own. Those are the individuals who are right now dying of lack of access to care that we want to provide access to. We say specifically that the way the mechanisms by which we save money are, as Wasik said, administration costs going from 18% to 2%, advertising 15%, 100% cut. Third, being negotiation, that the single buyer of the federal government is able to negotiate prices effectively to a fair range for everyone. And then third was the taxation schemes that the first affirmative speeches explained, how that goes on employers, not the individual people, since the employers are the ones who are currently spending most of it. My partner also explained how that means that they're actually taking in money that is already being paid out. So it's not some brand new taxes that isn't wishing money out of thin air. And the money saved from those efficiency gains is the way that we pay for those 28.5 million people to actually get that care. Yes, please.
Okay, so is your position essentially that since the status quo already has these issues, that we should continue to exacerbate these problems by overhauling the entire system and implementing this model that you're proposing rather than fixing the actual system in the United States?
Oh, hardly at all. Robert Frank, a piece of evidence that my partner read, once again the professor of management and economics from Cornell, said that the criticism of the current Medicare, Medicaid, and VA system results from the fact that the key problem is that they cover the population subgroups who require the most medical care, who have the greatest medical needs. Once you integrate everyone into one single central hub in a streamlined system, that is when those efficiency gains are able to be realized, and the pool can be risk adjusted, if you will, to borrow an old Obamacare term. Regarding what is actually going to be covered, because that was also a concern, we affirm that the coverage should be two things. First, universal, and second, comprehensive. Comprehensive means that there isn't rationing because comprehensive is already defined under federal law. Under the Affordable Health Care Act, there are 10 essential benefits, which are what is covered under comprehensive health care. If people want more beyond those essential benefits, then there is still a separate market for you to buy more supplemental care if that's something that you choose. Income disparity is also a huge problem, and that is where I mentioned before. I agree that is a problem that is happening in the status quo, and that is actually a reason that you should actually vote affirmative, because this is something that is doing something to actually alleviate those issues. One more thing that I want to jump back to is the first negative speech, talking about the doctor specialization and the likelihood of there being less research and development. This is a very basic economic principle that this is demonstrably false. The current problem is that there is not enough money for the doctors to then go pursue that degree, go into debt, and do everything necessary to make the investment for the R&D. When the government funds it, they guarantee a steady stream of funding at that level of demand. That guaranteed funding at a higher rate of demand means that the supply, therefore, increases. That takes care of the problem. It's basic economics. The only question is where the money comes from, and we outlined that very specifically in WASIC as to how that comes from, so that those efficiency gains can be realized and people can have their health care paid for. For those reasons, I urge you to vote affirmative, universal comprehensive coverage for the United States. Thank you.
The next negative speaker from the University of North Carolina is Alex Snyder.
Before I begin, I want to thank everybody for being here, both my opponents and teammates. Specifically, Paul V, thank you for bringing me up here to what is probably going to be my last debate tournament. Thank you to the audience, thank you to the judges, and more personally, thank you to my brother, Paul Snyder, who is not watching live, but I will show him this video so he knows that I thanked him. And with that being said, let's get into the key issues in this debate. My opponents made a key concession in the last round. They basically agreed with everything that my partner Pallavi stated. The underlying issues of health in the United States is caused by things related to income inequality, specifically diet, exercise, and environment. If you are living in a food desert and can only get your food from a gas station or from McDonald's, you're more likely to have health issues, you're more likely to be obese. If you can't exercise because you're working 2 or 3 jobs, then you're more likely to have health issues related to not exercising. Or if you live in an area of a city that has poor sanitation or is right beside a factory, you're more likely to have issues due to the air pollution in that area. These are the sorts of issues that are causing the underlying health problems that my opponents are saying is so bad. And it is cyclical. Look, my opponent literally conceded in the last round. He says, we'll solve all of that with universal health care. But that's exactly what we're saying is the problem. We need to prevent these problems from having to be solved in the healthcare system. By the time these individuals have to go to the hospital because they have heart disease, because they didn't have the ability to afford a good diet, by that point, the care is going to be significantly more expensive than if we just helped them get the food that they needed at an earlier age and earlier point in their life. That's going to be the significantly better and more effective way to solve the problem. And Pallavi talks about this. These intervention programs cost hundreds of thousands of dollars versus the millions of dollars that my opponents are talking about through their medical procedures. Sure.
If it is a good idea to spend that money to reduce that inequality, why not do both? Why is that a reason that the affirmatives plan is a bad
for
idea?
sure. Okay, so specifically what we're telling you is that if we solve these problems before they get to the issues to the level that they do in the status quo, we tell you that it'll drive down premiums that are causing healthcare to be so expensive in the status quo. So we literally solve all of the problems of people not being able to afford healthcare because the premium costs will go down. But furthermore, we access all of the advantages of a private system without the disadvantages of the public system, which we listed extensively on the negative. So let's go ahead and get into some of those. So the German model is the model that my opponents are arguing in today's round, but there are 2 fundamental differences between Germany and the United States. And I would actually argue that the current US system is what is allowing Germany to have the system that they do. So first, they don't have to spend money on a military. According to Bloomberg News, they're part of NATO. The United States is contractually obligated to come to the defense of all NATO nations. This means that countries like Germany don't actually have to spend as much money on their military, and therefore, because the United States will come and protect them. That's why, according to Bloomberg News, Germany has not reached the 2% of GDP spending levels that NATO is supposed to have them do. Go ahead.
So essentially, to provide universal health care, we have to abolish the military?
Okay, so here's what I'm saying is that Germany does not spend like they need to militarily because the United States does it for them. And if the United States did not spend what they do on the military, then Germany would have to significantly increase their military spending because otherwise they would have to deal with countries like Russia. If NATO didn't exist, imagine what Eastern Europe would look like right now. Think about what's going on in Ukraine right now. Imagine if the United States wasn't legally obligated by treaties to come to the defense of certain countries in Eastern Europe. That would be a completely different world, and I guarantee you Germany wouldn't be able to spend money on healthcare. I'm not going to take any more questions at this point. But furthermore, we also subsidize them in research and development. According to the International Business Times, the U.S. spends significantly more money on research and development than other nations do. And I would like to contest the statistic that my opponents brought up earlier. The National Institute for Health only provides about 1/3 of funding for research and development. The other 2/3 are from the private sector and the incentives that we talk about. Through international trade, we give that information to countries like Germany, and so they gain the access through international trade of the research and development in the United States without actually having to do it themselves. But we tell you that if we're going to drive down costs, like my opponents are saying we would under their plan, it's just going to decrease research and development, and it's going to decrease the overall effectiveness of healthcare because we're not going to be improving to actually solve diseases that we can't solve right now, like cancer. But finally, let's look to the quality of care. Remember, we're going to be driving down premiums because we're going to be solving health problems at their root cause, and therefore it's going to be beneficial. But specifically, my opponents keep talking about how under a universal system, we're going to be able to negotiate drug prices a lot better. But they don't look to specifically how the government-run healthcare in the United States works. According to the American Medical Association, when Medicare Part D was put in place, it was made so that Medicare providers legally could not negotiate drug prices with the providers. So this idea that we're automatically going to be able to negotiate drug prices isn't necessarily true in America specifically, based on our historical legal implementation of these systems. We can do everything they want to do better, and therefore we urge you to negate. Thank you.
The next affirmative speaker from Lee College is Vanessa Ringel.
All right, so I'd like to get started by saying thank you to JMU for running such a smooth tournament. It's been very fun thus far, and especially I'm very grateful for being able to make it to finals, and congratulations to all of my colleagues. And also a big thank you to my coaching staff, especially Joe Janakis, and sadly Christine couldn't be here, but I am very thankful for them, because without them and my wonderful partner I wouldn't be able to be here. So going on from that, we do have healthcare to talk about. So specifically, when we look to a story of Monique White, we see that on her 32nd birthday, Monique White experienced pain at such a debilitating level that she could not even open her presents. 3 weeks later, her body swelled and broke out in hives. She could barely sleep or do basic activities. She called her mom yelling, "Please, take me to the ER." And when her mom said okay, she broke down crying. "No, I can't, because I'm uninsured." And the next day, she seized multiple times and was swiftly rushed to the hospital. Monique experienced kidney failure, almost failing liver, and perforated intestines. Monique had lupus, which is a disruptive disease that attacks the immune system, and couldn't get proper step-by-step care due to being thrown off of the Tennessee Medicare program. She died 3 long months later in the hospital, leaving her mother to take on the hospital's extreme medical expenses. And this was a direct failure of the current healthcare system and a profound injustice to the taxpaying citizen. Specifically, when we look to the case of Monique White, we see that she was thrown off of the Medicaid system, the system that was supposed to provide for the individuals that were not able to guarantee themselves insurance through the private sector. And that is the problem, is that even when we look to reformations of the Medicaid system, it is still targeting certain individuals, and it's not guaranteeing the right that we have as citizens to health care. Further than that, we see that in the status quo, we have a total of, in 2008 and 2016, according to Time on January 2018, the average cost of an employer-sponsored family plan increased from $12,680 to $18,142. Not only that, but we see that the financial burden on these individuals is hefty, and we have to be able to act now to solve these issues. I will take the first of 2 questions.
Sure. So in an effort to cut costs, government healthcare programs oftentimes don't cover preventative screening, such as things like mammograms. How would someone who, say, has lupus be able to get things like blood tests as far as the government is not willing to pay for those unless there are symptoms that are detected for treatments later?
So what's actually so brilliant about this German model is that it's an adaptation of a private and public sector response. So whatever can't be provided within the public sector of the comprehensive coverage, you can actually go and have more disposable income for whatever you can't cover. Not only that, but there can be specificities to this German model that can solve for this. So moving on from that, we see the inherent problem within the healthcare system is that the current healthcare system is driven by profit without a desire to better the system. According to James Hamlin, MD, 2014, they tell us that massive hospital systems are buying out their competition without incentive to cut costs or optimize what they provide. Not only that, but this is a direct correlation to patent protections. If we look to the CEO founder of TechDirt on January 2015, it tells us that patent protection focuses on the short-term profit over the long-term health of consumers. The patents enable drug companies to up the prices to insane levels, and it prioritizes short-term narrow profits of drug companies over long-term contributions. And so with the German model, we can actually solve for this, because it is a collaboration between private and public sector. It is an adaptation, and thus we have more regulation for these insurance companies, for these patent protections, so you don't see those harms. And I will take the final question from the end. Yeah.
Okay. So this adaptation with the private and public, essentially the richer individuals in society would be able to use the private, while the poor would be able to use only the public. So how does that solve for the entire premise of your side's argument that this is going to solve racial and socioeconomic disparity?
So not necessarily. What we see with this adaptation is that, one, you have a choice to go to the private sector, to whichever insurance company you so choose. If you can't afford this, then you do have the option of government care. What we're advocating for is universal health care at its means and having that right as citizens. And that's why we ultimately solve. Not only that, but we actually look to disposable income. Specifically, when we look to to Health Affairs on March 2016, it tells us that universal health care actually allows for more disposable income within communities. This disposable income can then be given to these individuals for things like services, for food, for things that they cannot currently afford because of that financial burden from privatization only and market-driven insurance. Not only that, but we actually look to the right that we have as citizens to health care. According to CNN on 2012, we see specifically that the federal government argues that the insurance mandate is a necessary element of its regulation on health care market under the Commerce Clause. It is necessary, it is useful, and it is convenient. So our goal as a government is to achieve a right to individuals. Providing universal health care is an appropriate action of the government. This is not government overreach. This is simply protection of every individual citizen's rights to health care. Thank you.
The next negative speaker from the University of Central Arkansas is Dalton Cook.
Now, I know you've all already been thanked to death, but in the tradition, I'll go ahead and extend some thank yous myself. I'd also like to thank JMU and the Root Foundation for making this possible. This is one of my favorite events of the year, and I always appreciate someone giving me $1,000, so big thank you for that. I would like to thank my team, specifically my coach who's allowing me to be here, and my absolutely lovely partner, Jacob Holland, who is actually filling in for someone else who was supposed to be partnering with me, and it's just been absolutely splendid to work with. I love you, Jacob, and I'm so happy to have you here. And one last big thank you to Arkansas Tech University for allowing us to travel with them, because we didn't really have the funds to make this trip by ourselves. So big thanks to them. They're part of the reason why we're here as well. But that being said, we came here to debate, so that is what I'm going to do. By a show of hands, how many people here like going to the DMV? All right, I see we don't have any liars in this room. I appreciate that. Well, with the massive wait times that we see in German systems and other universal healthcare systems, going to the doctor may be like going to the DMV, taking a number, and waiting for the rest of your life to get your driver's license renewed. What we see in countries like the UK, which according to the Daily Wire and UK Independent has massive wait times, and also according to Quora, where in Germany specifically, they have wait times so long that some people self-medicate themselves. And now our opponents say, well, we don't actually see this happening in Germany. But let's look at how these systems are different. One, we see that these doctors aren't as high quality because they aren't paid as good. Second, we see that education in Germany is a lot cheaper than it actually is here, so you don't have to go through as much work and endure as much of a cost to actually become a doctor like you would in the United States. If you're going to be nothing more than a lowly government bureaucrat whenever you become a doctor, why should you go through the strenuous stress and cost that medical school would incur? Well, there's really no reason to. Another interesting thing I'd like to point out with this government bureaucratization, I don't really think that's a word, but we'll roll with it, is the fact that since we are federal government, I'm assuming that doctors will be federal employees, which means if they're not happy with their wages, since they have a union, they will be allowed to strike. Imagine how catastrophic a healthcare system can be whenever our doctors decide to stop working. Mr. Garcia, I will take your question.
Okay, so do you have a specific statistic talking about wait times in Germany and how they compare to the United States?
No, I don't have specific numbers, but I do have evidence that's alluding to the fact that they do exist, and so that's what I presented today. Another thing that I would like to point out is that the German solution doesn't actually solve any of the problems pointed out. As the affirmative team has brought up today, the German system has two classes that are de facto, one being the basic universal coverage, and second being the private coverage that you have to pay extra for, which means that the lower class people, the people who are impoverished, the people that need this health care more than any other person in the United States, under the system, still would not be able to afford things like preventative care, like our friends from Yale have pointed out, because they only get the basic coverage, which has massive wait times and poorly paid doctors. We see that a lot of the benefits and solvency that are coming from the affirmative can't even be solved by the plan that every single team has thrown their weight behind. So I don't see how we can be advocating for this today, especially whenever there is another solution, which is going to bring me to my next point. Now, it's funny that we're talking about healthcare Because in the medical field, I think typically what we want to do is avoid doing things like treating the symptoms and instead, if possible, cure the disease. Well, people not being able to avoid healthcare in the United States is in fact a symptom of a much larger cancer that is spreading throughout America, which is class disparity and low wages. Over the past few decades, inflation has grown, prices have gone up, and the cost of living has increased, while federal minimum wages remain stagnant. This means that not only can people not afford health care, they cannot afford anything: rent, food, and other basic necessities. Does this mean then that we should ask the government to foot the bill for every aspect of our life and live in a totalitarian socialist state? I certainly don't think so. What we actually should do is implement equitable government job programs, things like the WPA to work on crumbling infrastructure. There's another benefit for you, like Roosevelt implemented in the Great Depression, and regulating and increasing wages so that people can not only afford their basic necessities, but also things like health insurance for whenever these tragic things happen. So we see that these economic issues can actually be solved by not implementing a harmful system that doesn't even solve the problem in the first place. I will take one more question from Lee and then I will be finished.
Wouldn't having disposable income from universal health care solve for a lot of those harms that you're providing?
Well, considering that people wouldn't actually be able to get the care that you're saying that they get because of this two-pronged system, absolutely not. They wouldn't. The last point I want to make is about innovation and drugs. Now, this has come up a lot, but I actually do have some evidence to support this. Cohen 2006 that says national health insurance dampens medical innovation. What he says is that some of the biggest medical innovations actually come out of the United States because of things like Big Pharma, which I know everyone hates, but it's efficient in the fact that due to competition, it is able to fund things like biomedical technologies, research that in the long term is looking to come up with things like cure for genetic diseases like Crohn's, and even things like cancer. Things that, if you think about it, will really eliminate the demand and need for healthcare in it of itself over time, which would be a much easier way to solve these problems. So considering the affirmative system doesn't solve anything, causes immense amounts of harms, and there are two other ways to solve the healthcare crisis in America, we obviously must stand against the House and negate this resolution. Thank you.
The final affirmative speaker from Lee College is Leah Sparkman.
Before I get my speech started, I would like to echo the sentiments and thank yous of everyone else. Specifically, I would like to thank my boyfriend, Rigo Ruiz, my best friend, Alyssa Hooks, my wonderful partner, and my two coaches, Christine Corteau and Joseph DeGiannakos. Specifically, y'all have helped me get through to the point where I am at right now, and I'm very incredibly grateful. And I would like to also thank James Madison University for hosting a wonderful tournament. But we actually have some important things to talk about, so I'll get right into it. We affirm today's resolution to provide universal health care through the lens of the Germany model, specifically to protect citizens' rights, not overstep. So looking at a few arguments made by the negative, the first one we want to look at specifically is the massive wait times in Germany. When asked, Dalton was not able to actually provide how long the wait times were or the impact that they had on the German citizens, so therefore this is actually going to be a claim that does not exist on a scale to be impactful enough to hold within today's round. But then the second point that I'd like to address is specifically this idea that the lower class is not helped. But remember, universal healthcare actually helps mitigate costs and bring them down, so it makes it more accessible for people of lower incomes through this funding. But then the affirmation has a few points. Specifically, the universal healthcare idea helps small businesses. Universal healthcare provides greater access to the national identity of entrepreneurship. The Center for Economic and Policy Research, August of 2009, says an important part of our national identity is built around the idea that the United States offers an environment for small businesses that is unmatched anywhere else in the world. By every measure of small business employment, the United States has among the world's smallest small business sectors. The high cost to self-employed workers and small businesses of the private employer-based healthcare system in the United States may act as a significant deterrent to startup companies. So why is this important? Well, this creates haves and have-nots within society. Small businesses and large businesses have a disparity, and it worsens things like income inequality. When we're talking about income inequality, we should address the idea within healthcare, not just diet, exercise, environment, and these different distraction tactics that the negation is bringing up. But then further than that, we see specifically that this idea of the American dream is to build small businesses within America. In order to affirm this ideology, you have to affirm universal healthcare, because we are seeing small businesses suffer. But further than that, healthcare places an undue burden on small businesses. They have to have this healthcare burden right now. The small business community has felt the financial pain of our current healthcare system on the bottom line. So that was from Richard Fertel, LA Times, March 2018. This actually impacts the entire economy, because we see that these small businesses are the backbone of our economy, and it impacts literally every single citizen. But then moving further than that, when the negation says that universal healthcare harms the economy, we see that in the status quo, if we're harming the backbone of it, small businesses, we need to do something differently. We need to affirm universal healthcare. And that's the last point that I'd like to make, is going to be specifically going back to the Germany plan and how it solves. We looked at overspending compared to other countries. Health Law and Policy Brief, American University, Washington College of Law, 2014, talked about how we spend more than 2.5 times more per capita than the average amount spent by 34 countries in the Organization of Economic Cooperation and Development. Why is this significant? Because we're throwing money at a purely privatized system that has not been functioning and working. So the way that we have to fix that is with the idea of the adaptation that we talked about within the Germany plan. So what does the Germany plan give you specifically? You have a choice, but you also have a universal safety net in order to have these citizens that are affected the most in order to get this health care that they desperately need. So we see that without governmental overreach. But in conclusion, we affirm comfortably, because we believe in protecting fundamental rights of life, liberty, and the pursuit of happiness, believing in universal healthcare, and affirming the resolution is a step towards justice for Monique and the climbing rate of those uninsured currently within the United States. Thank you, everybody.
And the final negative speaker from the University of Central Arkansas is Jacob Holland.
All right. So I want to go ahead and give some thank yous as well. I can't really see people out here, but Anthony, Arkansas Tech, Leah Smith, who will be watching this later, Dalton, my wonderful partner for the weekend, and most importantly, my mom. I always wish that my mom can travel with me across the country. I don't think that we would have really gotten along on the day-long trip that we had here, but I do want to thank my mom for always supporting me in my debate endeavors. With that, we do have this great discussion going, so let's get right into this. The first thing that I want to do is go down this table and show you why each school really has not solved a major problem here. Lee College comes up here in the last two speeches that you hear from the affirmative, and they basically dodge the point that Dalton has made in the point that the affirmative is trying to solve a symptom of a problem, right? We hear Leah in that last speech say, well, why can't we just do this at the same time as, adopting universal health care? My problem here is you have lower quality of care and a good wage. When you do the negative plan, you have a good wage and better quality care. So we need to negate the resolution. But let's go further. When we look at the idea here that Lee College also proposes this idea of using private and public as this adaptation, right, for coverage. The problem here is they create that two-class de facto system while also trying to claim the benefits of solving racial and socioeconomic disparities within the healthcare system. They can't have the best of both worlds. This does not flow affirmative. When we go further, we'll see Liberty University comes up and talks about basically the decreasing administrative costs, right, and income disparity. They talk about income disparity because this is, again, the real disease. It's not the healthcare itself, it's the income disparity. But when we go further, we'll see that decreasing administrative costs, because these thousands of administrative jobs are now being cut, that's where the costs are being saved, we have people without jobs, thousands of individuals. And we see that doctors are having to take on those administrative duties, so they can't actually give you the time that you need and deserve when you come to the hospital. That's how logically obviously the wait times are getting longer. But when we go further, we'll see that also on this point of the German system, let's talk about this a little bit and really crystallize this discourse. My major problem here is we don't want to give the government the power to decide if someone's treatment is more important than another individual's treatment, right? We don't want the government to decide if the resources that they are allocating are worth giving to me or another individual. But going even further, we hear this wonderful concept of full access to care, but that access doesn't matter if it isn't going to be effective in solving your health issues due to its low quality. Doctors will no longer set their own pay under the German system, and hospitals, in turn, will give you less attention due to the time pressures they face due to the very administrative costs decreasing that they're talking about. Going further, doctors no longer have time to be doctors. If you need to see a doctor later in the year, he may have already reached the quota that the German government will pay him for seeing patients, so you'll have to catch him in the Bahamas on vacation. In no way, shape, or form is universal health care, the system, the best option. It is simply universal suffering as a system. Now let's talk about the negative world. In the negative world, we have an efficiently driven private sector utilizing competition in order to provide quality care. In the negative world, we have more innovation and less of a wait time. We have better quality of care, and we do not give the government rationing capability. Our doctors are not pressured by taking on the burden of administrative duties and others. They can actually be doctors. And going further, there is incentive for these doctors to actually perform well and stay up to date with research that they now have the time to do in the negative world. After life-threatening surgeries, our citizens can stay in the hospitals to be monitored rather than being rushed out the door like they are in Germany. We do not have situations like 10-month-old Charlie Gard, who was hospitalized with a very rare brain condition. And facing near death, doctors told his parents that he would be needed to take off of life support because he had no other options. They disagreed, raised the money to take him to America to have a potential life-saving surgery, but the government-run hospital would not release Charlie back to the parents' care. This is the abuse of power that we are talking about if we affirm this resolution today. The government should not decide which lives are worth the resources that they are allocating. This is absolutely wrong. Universal health care cannot deliver the health care quality that our citizens desire and deserve. And the affirmative is trying to solve a disease by solving the symptom. Thank you.
All right. Now the jury will deliberate while we invite the audience to make floor speeches and ask questions. While the jury is preparing for their deliberations, I want to take a moment to thank each of our competitors for your great research, the articulation of your arguments, your professionalism. And I would invite members of the audience to prepare to come forward if you're interested in speaking. There are microphones there at the floor.
This is my first time at JMU for this cup. I think it's awesome. And one interesting topic that came up today, I believe it's SMU who brought up the argument about teachers. He was using as an analogy, I think, but I think it was a really great argument. And I just wanted to kind of point out that, like, while we're seeing a teacher crisis in Oklahoma right now, I think we can kind of see that reflected in doctors whenever we talk about healthcare. You know, teachers are judged based on the test scores more often than they see the really big impact they make on the students themselves. So as an educator, a future educator, I think about that argument toward the doctors and how they're now being kind of judged based on how much money they make, based on what tests they do that cost more money, that make the hospitals more money. So I just think that's something that we need to reflect on when we're talking about healthcare and how it's being evaluated right now in other countries as well. I can't really say whether or not you believe that goes for one argument or the other, but I think it definitely needs to be considered. Yeah.
This one? Okay. Hi, Jonathan Williams from Arkansas Tech University. Question for second and third neg. So University of North Carolina and University of Central Arkansas. Your main arguments are not necessarily that the current system is bad, so to say. Like it could use some tweaks, and then we could go full private, of course. But really, your main arguments and your main problems are these other things, these other debates of the food you eat, your environment, your exercise, the amount of hours that you spend at your job. Those are really your main problems with our society. Therefore, healthcare can come later because we've got these major other issues to solve, correct? More or less, yeah. More or less, yeah. Okay, thanks.
Don't worry, guys.
Hey, what's up? Okay, good. We're here. All right, so fantastic. Is there any kind of time limit on floor speeches?
No.
Fantastic. All right, don't worry. I'm going to be considerate. I know that's not encouraging for the audience here, right? Okay, so what I want to say is, first off, congratulations to all the debaters up on stage. Y'all did a fantastic job. I think y'all brought up some things that definitely need to be heard. We definitely need to talk about this. But there's some things that I came across in my research over the last couple weeks preparing for this topic that I think I'd like for a larger audience to be able to hear, and I didn't hear espoused from the stage. So I'm going to do that now. I want to talk about the healthcare system and how it is bizarre and dangerous, right? So the U.S. healthcare system has some issues with it, to say the least. So imagine that you are creating from scratch a healthcare system for a society. You would never in a million years do the one that we have decided upon here in the United States of America. It just doesn't make any sense. Does this come out? Perfect. Right, so the primary way that we've chosen to organize it is we have insurance companies, right? And the way that an insurance company works is it's a private organization, and it gambles on the people who are patrons of it, right? It decides, okay, you're probably going to pay me more money than I'm going to have to pay in your health insurance costs, your health care costs, right? This is a totally perverse system, because what it incentivizes them to do is to find the people who need their services the least, and that leaves people who actually need health care out to dry. Like, for instance, until very recently, if you had a pre-existing condition, you were SOL if you needed health insurance, my friend. My brother has diabetes, and that was an issue for him for a long time until recently, right? So we see that from the ground level, the system is kind of screwed. So it evolved a little bit, right? And then we saw that healthcare became something that was expected to be covered by a business, by your employer. And then that became codified into law. But that has some perverse effects, right? Like, for one, it's obviously not very good for the business owner. Like, a small business owner isn't going to have a very easy time providing insurance to its employees, because if I've learned anything over this day, it's that healthcare is expensive. And so that's going to stunt economic growth, especially small business growth, which is great because it returns money to our communities, right? It's also bad for employees because it provides you with less economic freedom. You can't go out and do what you want. You have to be chained to some business because it's what's going to pay for you if you break an arm. And that's not what we need for us, right? It's also bad for consumers, by the way, which all of us are, because it's not like the companies are just going to eat those costs. They're going to be passing them along. So, like, there's some issues baked into the fundamental core of our healthcare system. And, like, obviously there's a million other things wrong with it, but y'all don't even want me to take the time to go over all of that. So I'll continue into how it's dangerous, right? So the system is dangerous because it's got a really bad combination going on where we see rampant growth of cost and rampant growth of debt, right? So healthcare providers, healthcare companies have had their debt increase 308% since 2009. That is an insane amount of debt growth that is unsustainable and frankly dangerous, right? We also see that the cost to provide healthcare to a family of 4 is nuts. We see families having to pay as much as $26,000 per year for that family. That's undoable. These two things growing together inevitably is going to lead to an economic crisis, right? There are experts outside of just this guy standing here with a mic who agree with this fact. So this is a problem, and the thing is that when this happens, there will be no bystanders, only victims. It's going to drag the economy down with it. It's what the new recession is going to be caused by. And that's the danger that we see, and we don't know how bad that could be, because people are likely to panic when their health care goes away. So there are people who try to tell you, obviously there are people in this nation who don't think we can do it. They don't think we can pull off a universal system or any system that's better than ours. But when the city of Chicago needed a sewer system, we raised it 4 feet off the ground to do that. Within one lifetime of having discovered heavier-than-air flight, we got ourselves to the moon, and we harnessed the power of the atom. I really just don't buy that that's something we can't do. Thank you very much.
Okay, I will try and be slightly more brief than my My teammate, Mr. Beckham, he clearly likes debate too much. Very quickly, as you may have picked up already, if you don't know me from my accent, I'm British. So I am used to the NHS, and I think it does a wonderful job because you don't have to worry at all ever, okay? If I get sick, I don't have to think, oh my God, can I afford this? And this is a massive point that like no one, I think, even thought to make because you wouldn't even think of it until you don't realize it's there, right? The fact that I can just walk into a doctor's office and they see me and I not have to worry about what my credit card limit says is a massive benefit to the fact because when you're sick, the last thing you need to be is sick and really stressed out. Because if anything's going to stop you getting better, it's the fact that you're also really stressed out. And then the other point I'd just like to make quickly is that literally the American government today spends more money on healthcare per person than the British government does per person. How can it possibly be that government, like quote government, can't run a system that is cheap when literally every other government in Europe does it, right? There are, I guess, political issues that we could go through to why the American government spends so much to drug companies on like Medicaid expansion and that, but clearly the problem here is not government because every other government of major countries of the world has sorted it out. I think if there was a finish this speech, it should be, come on, America, get your stuff together. Okay, the rest of the world's done this already. Please join us for the sake of your people.
So this is a general JMU announcement. If you have a ballot, there'll be JMU debaters coming to collect it, so A, we can see who the audience thinks won, and so if you're a JMU student, you can actually get SONA credit. So make sure you give your ballot to the JMU debaters who will be up and down the aisles. Not a question, just an announcement.
Thank you all so much. I'm a representative from Lee College, and I think it's incredibly important to note that the second and third speakers on the negation are advocating for a private partnership that allows for, they say, more innovation, and it allows for doctors to set their own prices. But what we see uniquely is this plays directly into the profit motive that we see harming our current system, that further disenfranchises minorities, but even further than that, it makes healthcare less accessible. So to the second and third negation team, how do you access this right without actually allowing for people to access their own healthcare system?
So, it's a really good question. I don't particularly recall advocating for any specific system in particular, like you're saying we did. I was under the assumption that we were all sticking within the status quo. Am I right on that second negative?
Yeah, the only thing that we were advocating for is some maybe intervention programs earlier on to like make it so that people have access to better quality food, are educated about things like diet, exercise, and maybe have some pollution standards to like improve air quality in certain areas. So
Yeah.
that's really the
And it was it was the side of the affirmative that took the German plan, which literally is that two-class de facto system, public-private. That's where we were talking about public-private. We were pointing out the flaws in the German plan, and that's where that came into the debate.
And I believe our consensus was that it was bad. Yeah, it's my turn. Go ahead.
And I think the core of it was more just that, like, it's a lot easier to intervene in these other ways. Like, it costs a couple $100,000, but like healthcare can go into the trillions, billions, millions very easily. So better to pay for it early than late.
All right, thank you all very much.
You're welcome.
Hello? All right. Also from Lee College, and as much as I'd love to live vicariously through my girlfriend on stage, I just want to give everyone a little story about myself, and don't worry, I'll make it a little brief. I'm a small business owner, and I love the argument presented by Lee College, i.e. that's kind of why they ran it. But what's really important is that oftentimes we tend to forget about the small business in that that's essentially the foundation of the United States. That's what we were created on, small businesses. Everyone wanted to come to the United States. And unfortunately, over the last half decade, we've seen that income inequality, that's what the negative was actually running, kind of get worse and worse. So I would like for everyone to really take into consideration what it actually means to be a small business and the clear burden that something like healthcare actually puts onto them. And I know that the affirmative actually ran that idea, but I don't really think that people really take into consideration where we were when we started to where we are now. And I think that that's something that we all need to take in mind moving forward, because everyone's a little entrepreneur. Whether it was that little lemonade stand that you started when you were a little kid, or that little toy you wanted to make a patent on. Unfortunately, you can't do that, little Tommy. But I really want everyone to understand that. Thank you.
Hey, I have a question for literally anyone on the affirmative. So, something that we have in the United States that we don't really see in countries like the UK or Germany or whatever, is that the United States is pretty much at risk for a government shutdown at any time. So if the government is shut down, how are we going to ensure that people are going to have access to their universal health care?
So, along with government shutdowns, we see that functional, like, services that we have to have still operate, right? Like the post office still operates, the police still operate, the fire departments still operate, the military still operates. So,
Hospitals.
yeah, like the healthcare system has to run. The healthcare system is vital to like the country existing, and so that's something that would not be affected by a government shutdown.
Thanks.
Hang on. All right. First of all, congratulations to everybody on the stage there. I think you guys did a very great job. My question is particularly towards the negative side. We heard a lot about how preventive care and primarily how we can solve this problem beyond or like before it happened, but what about like the current situation? How do we solve what's happening right now more than focusing on what might happen in the future, which I do understand is a good concern, but like what do we do of the current system? Like,
Jump in here again. So I think that it's really, really hard to solve problems that are happening right now. We live in a heavily there's a lot of bureaucracy in our government, and it's very complex. It has a lot of different moving parts and working systems, and I don't think that no matter what reforms that we're making or not making, we're going to be able to solve what's happening right now. It's going to take a lot of progress over a significant amount of time, whether you're looking at this from an affirmative or negative perspective.
thank you.
All right, I just want to touch on the point. We talk a lot about how small businesses and how this having universal healthcare would ultimately be beneficial for them, but maybe looking at the employees, people who are actually going into businesses, because a lot of health insurance is employment based, that really kind of limits the choice of people who don't have a lot of means in what jobs they can actually get. For me, I don't have health insurance. I haven't had health insurance since I was 19 because I got kicked off of Medicaid. I don't have the money to actually afford private insurance, and I'm from Mississippi, which isn't really known for caring about the health and well-being of people. So essentially, my job opportunities are going to be limited dependent upon where I can get health insurance and what job that I can have that's going to give me health insurance. So in a universal system, which I firmly advocate for and believe in, I feel like I would have greater employment opportunities just in variety because I won't have to work for a giant business or a large company that is able to provide me. If I wanted to work for a grassroots organization or if I wanted to work for a small business, I would have the opportunity to do that. So yeah, I just wanted to kind of take the small business argument and kind of put it onto the employee and like how that can be beneficial. So yeah.
Okay, so I just had a question. First off, congratulations to each of the teams for being here. As a coach, it's always really cool to see young people really take to a position and take the time to research it and really apply that. And so that's really where my question comes from. So I've seen most of you grow and develop over the years, and I've got a chance to watch some of you guys as spectators and have immensely respected each of you guys. And so my question is really, taking what you guys have learned through this research, how does that actually inform your decisions on a personal level considering this topic? I think that that's something that's really important to consider, not just in the context of a round, but like, does this actually mean something for you guys? And so really just to kind of hear, from anyone who would like to answer that question.
Okay, so for me personally, I always considered myself like extremely liberal, quite leftist, in the sense of I was always a huge fan of like single payer options and whatnot. And I like always would advocate for those types of systems. But I think in terms of researching for this more specifically, I realized at least in terms of U.S. like institutional problems, i.e. what I think is actually a real lack of doctors and just like lack of access to medical systems, especially because the U.S. government has far more bureaucracy than a lot of the Western European countries that have these single-payer systems. I think that makes it much harder for the U.S. to actually implement these programs successfully. So I think this made me genuinely question what my thoughts are on these healthcare systems, and probably actually lean towards advocating for more of what we sort of talked about around reforming current Medicare and Medicaid systems, rather than trying to do a single-payer system, which I think, at least within the U.S., is probably more likely to fail.
In addition to what was just said, I know for me, I've been doing debate for a few years, and I always like to remember that these debates don't exist within a vacuum, and this debate really talked a lot about the healthcare system. But whenever I analyze a topic, I try to look at how healthcare systems fit within the system, like the financial system, or the state system that we have in the world, and how that affects healthcare policy and how healthcare policy affects that. So that's why, in topics like this, I do like to see how things like military spending and geopolitical situations with NATO do actually affect the healthcare system. And I know that wasn't something that other teams brought up, but I think it's something really to think about when it comes to the defense situations that countries in Eastern Europe face. How would that look different if they didn't have the U.S. as an ally? How would that affect their healthcare spending? I think it's something to legitimately think about. Outside of what I said in the round, it could go. It's something worth looking into, and how that affects U.S. policy. So I always try to analyze the system, not just the specific issue.
My question actually follows up on that. Looking at and there was a lot of argumentation about how we've slipped in terms of our level of care compared to other countries. Where does that fall in terms of the countries that have greater levels of health care than we do? How many of those are either NATO or treaty-allied nations that we are actually underwriting their healthcare system through our military spending to protect their assets, interests, et cetera? Does anyone have that information?
So I don't have the specific number, but I do know that a good amount of the countries in the OECD are part of NATO, especially throughout Europe. And so usually I bring up that argument in the context of the Scandinavian countries, which definitely are part of NATO, or even Germany, which is part of NATO. And that's one of the reasons why I brought that up in this round. But no, I don't actually have the overall numbers and how it compares NATO versus single-payer systems. That's a good question. Like I said, something I feel should be looked into, just for everybody interested in this topic.
I have a question for Lee College. You got us on this track of talking about how the current system is bad for small businesses because it's too expensive for them and unfair. I just want to know how this interacts with the pay-to-play and employer mandates of the current provision of the ACA.
Could you explain the mandates a little further in connection with that so I could have clarification?
Yes, what it says is that all businesses with more than 50 employees have to either provide some kind of insurance to their employees, or they have to subsidize it or get them some kind of agreement, and if they don't, they're just penalized with a small fine.
Yes, definitely. I was inspired to talk about this specifically because my boyfriend is a small business owner, so I know that directly impacts them very significantly, and sometimes
But how? Because they're not a small business if they don't have less than 50.
Do what?
You're not a small business if you employ more than 50 employees, and if you do employ less than 50, then you don't have to pay this.
I still consider those 50 is probably more of a smaller company it could be specifically.
So even if it's not classified legally as a small business, there is still substantial significance within these businesses that we classify as small, not legally, but just in general, because they don't make as much revenue as you would see from big corporations, big companies. And so ultimately, it's that they just simply do not generate enough revenue to be able to cover all of those employees' insurance, which is made by that mandate that they have to cover. And so 50 is I think 50 is a very bad number to use legally, because 50 does not automatically imply that, okay, at 51, now you can actually afford it. There are so many factors when it comes to business models and businesses that ultimately that's not a good number to use. And so these are still small businesses, even though we don't legally define them as so.
Okay, so there's actually a lot out there talking about like some people that own small businesses won't actually hire that 50th person because of the cost of them having to then pay for health care. And so with this mandate, like I personally don't agree with it being at 50. I think at that point we're taking away more jobs that could actually exist, because if a company's not making a whole lot of profit but they have to have a lot of people to actually operate, now we're pushing them into a hole where either they start losing money or they just don't hire any more people.
Thank you all so much. I had a lot of fun today watching so many of you debate, and then I decided to show up and see how it's going to turn out. So thank you for a great day. So this is one of those really annoying question comments that I have for everybody. One of the things that I think I would have liked to see parsed out more by the AFS and the NEG teams is the difference between having access to healthcare versus access to medical professionals. In a lot of the work that I do research on the reasons why people who, although they have medical health care, they still don't receive quality care. For example, there's a lot of research coming out about the biases of medical practitioners when it comes to making decisions about who they will accept as new patients or clients, and how stereotypes and their prejudices about race or socioeconomic status or language, the way that people speak will affect whether they're accepted or not. And then I guess this is more for the people who have been arguing for the negative side all day. One of the things that I think could have really enhanced your arguments, not that I think that they were bad in any way, would have been perhaps some discussion of the ways that we're trying to increase access to care through technological means. Right, so the growth in telemedicine has been really important and could have definitely, I think, contributed to arguments for the privatization of care. We've seen a lot of corporate interest in that, as well as through insurance companies, and not as much from a federal government level. So I guess perhaps if you continue to do these arguments, I think that that could be really beneficial to consider. As well, if you look beyond the purview of insurance companies, a lot of growth in technology sectors, people who are interested in creating applications, interfaces for computers, and to put people in touch with mental health professionals in other locations. I just think technology is a great way to look to enhance your arguments. I don't know if any of you thought about that and decided not to include any of that, or if that's sort of been beyond the purview of the evidence you're considering.
So that's a great point. I think we probably should have done more research on it. I actually have worked in digital working automating those services, and yeah, that's a great point. We probably should have used it.
Yeah, I just think it would help you guys a lot.
Yeah, and we had information about access to medical professionals and healthcare in general, and some stuff about technology. I think the main problems we run into is that there are so many specific details and arguments that you can make, and sometimes it's hard to figure out how to prioritize and what arguments you can make because there's such a limited amount of time. So it's something I certainly would have liked to go into if I got to talk for as long as I wanted, but then you'd all have to listen to me ramble for 3 or 4 hours, so I don't know if anyone would enjoy that.
Okay. Yeah, I just think it's a great way to kind of negotiate giving people care without necessarily universal coverage. But thank you, guys.
Are there additional questions or speeches from the floor? All right, well, we will await the return of our jury then.
All right, we have a decision, but before then, do we have an audience award?
We do have an audience award. So the award for the speaker from the floor goes to the gentleman from Mississippi, with a red tie, who spoke to the impact of health insurance options on employment opportunities. No, yes.
All right, let's give one more round of applause to the debaters and to the judges. So after a very close deliberation, we have a decision. In third place, receiving $2,000 for their university, is Bosher Parish Community College. In second place, receiving $3,000 for their university, is Yale University. And in first place, receiving $5,000 for their university and $2,000 each as their individual prize, is University of Central Arkansas. Congratulations, everybody. We'll see you next year.